Hello and welcome to this presentation on delayed discharge in Scotland. Delayed discharge is when a hospital inpatient who has been judged clinically ready for discharge by the responsible clinicians in consultation with all the agencies involved in planning that patient's discharge, and he still continues to occupy the bed beyond the ready for discharge date. In layman's terms, that means when a patient is ready to leave the hospital but cannot as a result of circumstances not directly to do with the patient's health. This is a problem in hospitals as the number of available beds in a hospital can often act as a bottleneck when it comes to patient care due to the limited numbers. It is widely accepted that there are three main reasons for delayed discharge. They are number one, health and social care reasons, number two, patient and family related reasons, and number three, complex care needs, which is more commonly referred to as Code 9. These include the patients waiting on the availability of care homes. Despite these definitions, it was found in our group that these three reasons can often be subject to varying definitions between institutions. In terms of data analysis, our group used 2016 data from NHS Scotland and the UK government's online resources. This first graph shows the reasons behind bed days used in hospitals in the year 2016 in Scotland. Independent patient and family reasons accounted for 2%, and Code 9 reasons accounted for 24%. The next graph depicts the length of stay of each of these delayed discharges across Scotland in the months July, August, September, October, and November. Please note the significance of only 20% of all delayed discharge cases being less than 6 weeks across all 5 months. This means that 80% of all of these cases lasting longer than 6 weeks. This third graph shows how all of the cases that take longer than 6 weeks are segregated. It can be seen that Code 9 and health and social reasons account for the vast majority of these delayed discharges. This is an important result as it highlights that these two situations take up the bulk of bed days due to the cumulative effect that longer stays have on these bed days. This graph shows the number of bed days on the y-axis against the months of January through to November of 2016. The data represented here shows how all of the bed days in this time period were used by two age classifications. The data represented here shows how all of the bed days in this time period were used by two age classifications, 18 to 74-year-olds and the over 75-year-olds. It can be seen that the over 75 age group occupy what accounts for a mean average of 70.3% of all bed days in this time period, as opposed to the 18 to 74-year-olds who have a much larger population. Nottinghamshire was a case study that was decided upon due to it having the best statistical record in England in regards to delayed discharge. In addition to our analysis on Scotland, our group decided to find an example of a highly successful area in regards to delayed discharge in order to investigate how and why this example was so effective. One key finding that set aside Nottinghamshire from other counties was its so-called Plan, Do, Study, Act cycle. What this accounted to was the implementation of a change in discharge strategy whereby medically fit patients were discharged by midday as opposed to the prior method of discharging these patients between 6 and 10 p.m. As a direct result of this change, roughly 40% of the patients were discharged before 1 p.m., up from 14% prior to the PDSA. Additionally to this, the number of discharges became more evenly distributed throughout the day, as can be seen in the graph. Another outstanding method used in Nottinghamshire was the use of alternative accommodation, which included homes of relatives and specialised council housing. This method proved to be highly applicable to patients whose homes were not deemed suitable for their current medical conditions. By using these alternative accommodations, patients' quality of life improved, large sums of money were saved, and hospitals were more flexible at dealing with patients with complex needs. Another noteworthy method used by Nottinghamshire was a so-called cluster method. This method distributed 18 social workers to specific department clusters within hospitals. The role of the social workers is to then act as a link between doctors and nurses, etc., as well as being in charge of the appropriate patient's future care. In addition to this, daily meetings are held to discuss progress and possible delays, as well as patient social care needs in advance of their discharge. As previously mentioned, the main individual reason for delayed discharges across Scotland is Code 9/complex care needs. In order to address this issue, one recommendation that can be made is to further the work done with local partnerships across Scotland to help people cope away from the hospital who are still in need of professional assistance. This would help free highly demanded hospital beds, as well as ensure that patients are able to leave the hospital at the earliest appropriate time, as it can be detrimental to patient health staying in hospitals for too long a time. Tangentially to the point above, an increase in the number of hospital beds would be an adequate solution to this concern, whereby the issue of patients overusing hospital beds is addressed. Although supplying more hospital beds does not necessarily reduce the problem of delayed discharges, it does, however, provide a solution to the main consequence, i.e. hospital beds not being used. Obviously, this is a highly debated topic with a lot of subjects due to other implications that this issue has attached to it. To further this point, this seems to be a growing problem in Scotland, as in addition to Scotland having an ageing and rising population, there has actually been a reduction in the number of hospital beds across Scotland by 600 between 2015-16 and the year before, as well as more than 5,000 since the year 2006-2007. Therefore, it has to be recommended that the number of hospital beds should be increased. However, it is understood that this is a very difficult solution to undergo. Another recommendation would be to establish a uniform definition for all the providers of data for each type of delayed transfer of care or reasons for delays. This is because minor altercations and clarifications could lead to large changes in the statistical results. One recommendation taken from the Nottinghamshire case would be to implement a small plan, do, study, action cycle, whereby the medically fit for discharge patients were discharged by midday, as this method seemed to yield very successful results.